Welcome to the October 2022 version of CFP Distilled. My name is Dr. Simon Moore.
And I'm Dr. Paul Dillon.
We are here to talk about the most clinically relevant and exam relevant articles from the CFP Journal this month. Let's start, as we always do, with our cover critique.
Huge improvement from last month. Last month had way too much going on. The world, the paper, people facing all of our blurriness. This time we have a small infant turning to a ghost, turning into, I don't know, like a 6-year-old on a hopscotch. I think much cleaner. Not really sure if the yellow and blue colors work together, but much improved. I'd still only give this a 6.
6 out of 10. All right, I get track and field. That's about it. Let's dive in. Elder abuse. If you haven't found it in your practice, that means that you're missing it in 4 to 10% of people. And what are the kinds of elder abuse that people should be able and ready to list on a SAMP exam or identify on a SU exam?
So I think about my spidey senses tingling, and you know something's wrong, but there's 5 domains. So there's this like web of neglect. So number 1, neglect. And then you're thinking about physical, psychological, sexual, and financial. And I think that sexual one is important to remember because we don't want to think it's happening, but it is happening. 4 to 10%, I believe, are the numbers of those that suffer from elder abuse. So think of that web and those different things. So neglect, could it be psychological, physical, sexual, or financial?
All right, so let's imagine that Paul is an elder. He's coming into my emergency department, and I'm noticing you got an injury here, you got an injury there, you got multiple injuries. How did these happen to you?
I'm just really accident prone, Simon.
And when did these happen?
They happened a while ago, but there was this weird delay between when the injury happened and when I came in, so a time delay.
And you've been here over and over again, so right there, you should be able to identify for a SAM question what are 5 indications of elder abuse on a history and exam. So the first one being that the injuries are unexplained.
That there's repeated injuries.
The patient's saying that they're accident prone or a history that suggests that.
That delay in time between the injury and presentation.
And the last one's going to be recurrent visits to the emergency department for repeated and similar injuries. And there's going to be a few things you might pick up on physical exam.
So they might have poor eye contact. They won't be looking at you. They could have fear of coming in. What about my personal hygiene state if I was that patient?
Exactly. Hypothetically, your hygiene is terrible. I'm glad that you dressed up for the part, but you smell really bad, your nails are awful, and your bruises are healing in multiple different stages.
Yeah, so the bruises are inconsistent with that mechanism. So those are the things you're going to look for on physical exam. So loads that could show up in a SU or a SAMP at the CCFP exam and in your clinical practice. So don't miss this.
Another important thing to know about SAMPs is it's reasonable to answer none. And so that's always got to be in the back of your mind. Is that what they're looking for when they say which physical exam findings or which laboratory tests would you do in a patient with elder abuse? Is the answer none? Well, look closely at the CFP Journal article.
So according to the article, there's a couple of things that you're looking for. So are they dehydrated? Are you going to check their renal function? Now you can't write renal function, but their EGFR, their creatinine. Have they been abused? Have they been hit? Have they been lying on the ground and they haven't been lifted back up from bed? Do you need to check their CK? So there's a number of different things that you can look for.
And finally, there's an easy tool. It's called the Elder Abuse Suspicion Index, EASI. It's a validated screening tool to help you identify folks who might be suffering from elder abuse.
So have a look at the tool, have a look at the article. I think it'll be a great help in clinical practice in picking up these cases and providing a bit of evidence for your practice.
Next article is on vaccine safety. You need to know about special populations. Vaccine safety in pregnant, infant, elderly, the PIE method we teach at the review course. This CFP Journal article talks about another special population, those who are undergoing cancer treatment.
So really when we talk about PIE in that cancer PIE, the immunosuppressed PIE, so pregnant, infants, and elderly, a PIE approach, the other piece in that I is the immunosuppressed. It's a broad spectrum, is a broad kind of ingredient in that PIE. These are the ones you need to think about. The big thing I want people to remember is live vaccines. So if there's a live vaccine, you're going to avoid it in those that are immunosuppressed.
So if I was a SU question writer and I was trying to get a superior certificate mark.
A superior?
Putting the SU into superior certificates. Or maybe I'm hungry, I just want to put the soup into superior certificate. I'm going to make sure that I'm saying what else is going to be involved in management. Not just vaccinating the patient, but who else should we be considering and recommending vaccination for?
We love to say at the review course, no patient is an island. There's someone else involved. So vaccination of the patient's family is now strongly recommended. So there's something else that you would advise the patient on for vaccination.
So the final article from this month's CFP Journal is another rapid review. We've got a whole list of rapid recommendations from Canadian guidelines that you need to know for your CCFP exam. So let's dive right in and talk about those with ureteric stones. If they've had a CT scan, is that adequate to diagnose it?
So Canadian Urological Association is saying, XR, what? Pause. Why? I go straight to CT KUB in my local center. But what are they saying? They're saying ultrasound, renal, and a KUB XR are the two investigations that you need. So if I was asked this question on an exam and I'm asked for two investigations, it's not going to be CT KUB. I'm going to follow these guidelines. I'm going to say these two.
This is national guidelines, and it's amazing because I know you're thinking they've got a CT. Just look at the Scout film, just look at the 3D view. But even with all that into consideration, the Canadian Urological Association found that if you've got all that and you add on an KUB X-ray, you're going to increase your sensitivity at picking up these ureteric stones.
So now, caveat, real clinical practice, you're going to have to follow what you're doing at your local center and what you have available. You might not have ultrasound at night. So think about national guidelines. This is a national guideline, so think about that for the examination. And remember the context of the question you are being asked. The context matters, where you are matters, so remember that for the examination. What's next for sexually active individuals under the age of 30?
So you're going to screen them for chlamydia and gonorrhea once a year, every single one of them, according to the Canadian Task Force on Preventive Healthcare.
And now let's stick with that topic of STIs, pregnancy. That's a pretty solid sexually transmitted, it's not an infection.
Maybe sexually transmitted
condition. It's not a disease, but if you talk to someone with 2 kids or 3 kids, it can cause some
there is some morbidity involved.
Some morbidity
involved. Some parental morbidity indeed. So the fascinating recommendation here, it differs than some of your provincial guidelines. Those of you in Manitoba might say, we don't do this in our province, but the SOGC is saying all pregnant people should be getting a complete prenatal sonogram between 11 and 14
weeks. 11 and 14 weeks, those are the times to remember. SOGC guideline. Sticking with the SOGC, tissue selective estrogen complex, or TESC, and Tibolone. It's a synthetic steroid, represent 2 progesterone-free options for treatment of post-menopausal vasomotor symptoms. So 2 things to think about. So synthetic steroids and TESC, tissue selective estrogen complex.
The next recommendation, also from the SOGC, about patients with vaginal atrophy. No, we don't call it vaginal atrophy anymore. They now call it genitourinary syndrome of menopause. So you know the first lines, those aren't even covered in this article, but you know that the first lines are going to be lubricant, because that can affect the pH and bring things back to normal and reduce symptoms. Topical estrogen, also first line, but at the CCFP hospital on the SAM exams, you need to be ready for second line. So pause the video if you don't know what are the second line indications for genitourinary syndrome of menopause. We'll tell you those right now. What are they?
Ospenephine and prastenerone. God, they need better. Prasterone. I can't. We need to look up at some stage.
You need to pause the video. Pause the video.
Progesterone the video.
Not progesterone.
And remember that you can use trade or generic names. So hopefully they'll have some really cool, easy to remember name as well.
And let's wrap up with symptoms of depression. Your patient is 65 or older. Could you name 2 first-line medications for that patient?
So duloxetine and sertraline for depression. So what do you need to do? What do you need to remember to bring those patients up that are down? Duloxetine or sertraline for those that are over 65.
And now another special population. If they are perimenopausal, they have depression, what are your symptoms and what are your, outside of vasomotor symptoms, what is your treatment of choice for depression?
So the SOGC, to come back to them, so a load of new guidelines this year and a load in this journal is hormone therapy for those patients, irrespective of vasomotor symptoms. So if you've got a patient with depression, you've got to be thinking about hormone therapy as well.
So that's a wrap for our October 2022 review of the CFP Journal articles. Now, one last thing we want to mention. We hope to see you at the review course, spring 2023. Where are the cities we're going?
We're going to Vancouver, Toronto, Calgary, anywhere else?
Oh, that's right. We have been dreaming about this for years. You've been asking for it. Let's beat the Canadian winter. Let's go to somewhere sunny and hot in January.
Las Vegas in January. Kick off your studying. Be the first person in your program to have reviewed all the 105 topics in one weekend. Come join us in Las Vegas in 2023.
Viva Las Vegas. For CFP Distilled, my name is Dr. Simon Moore.
And I'm Dr. Paul Dillon. Until next month.
See you next month.